Good evening and welcome to a wonderful second session of Nutrition Update for Nurses with Jamie Pope, who is an amazing author, writer, adjunct assistant professor of nutritional sciences at Vanderbilt University School of Nursing, and many more things. So I can't wait to share more with her. My name is Hannah Lowe. I'm a nurse practitioner and registered dietitian by training, Vanderbilt alum. And we are thrilled at the amazing response and time we've spent with people already. So welcome this evening. One thing Jamie and the team and I were talking about before we joined was the amazing amount of questions that people have brought to our attention. And we're thrilled with that. But we do want to say that we may not be able to get to all of them. We want to cover some topics that we think will hit on many of them, and we can give resources. But we know that there's so much to explore, and we'll look forward to having continuing opportunities to come back and share again. So with that, I'm going to let you kick it off, Jamie.
Thanks so much, Anna. I'm delighted to be back for part two. We didn't anticipate a part two until the end of part one, when we didn't really get to everything and we just had so many questions. And as Hannah mentioned, the scope of the questions, the extent of the questions truly are beyond what we can address in even two parts. But it's also exciting for Hannah and myself as registered dietitians to just see the interest and the diversity of the questions. And it's hard for us, even as dietitians, to keep up in this field. So much is coming out so often, so constantly. So just to get started, again, I'm Jamie Pope. I have been at Vanderbilt since 1986, yikes, and with the School of Nursing in varying capacities since 2000. Whoop, I didn't mean to do that. So just to give a kind of recap, in the last part one, in case you missed that, we did talk a little bit about dietary reference intakes, what forms those, gave you information on those, on how our needs are basically determined based on a variety of factors. And I gave several resources in that first set of talks. And today we're going to do more. So here's a couple here just for your ease of convenience, a DRI calculator where you can enter in different variables and calculate for yourself or your clients, patients, their basic needs in terms of vitamins, minerals, energy, macronutrients. We also talked some about the newest edition of the Dietary Guidelines for Americans, which are truly written with health professionals in mind. They are now organized by life stage, which is a new occurrence. And I gave you the link there to those guidelines, which have some very specific recommendations and information that you can kind of peruse and look through life stages. And then we also talked about dietary supplements, which is an area in nutrition that is definitely one that is changing, evolving constantly, one that is hard for any practitioner to keep up with the extent of the supplements that are out there, their efficacy, their safety, their contraindications, their interactions, all those kind of things. So I did provide quite a few resources where you can have this kind of information available at your fingertips if you get questions or even to refer your patients to. So today we're going to talk a little bit about evaluating nutrition information, also looking at a little closer because we got a lot of questions related to some popularized diets, questions about obesity. So we're going to touch on both considerations in treating obesity, particularly from a dietary standpoint, and then also a little look at some of the popularized approaches because we got questions on keto, we got questions on intermittent fasting, we got questions on Noom. So we got all kinds of questions related to some of those popular diets. Of course, we can't address or go into detail about all of those, but my hope is to give you, again, credible resources at your fingertips where you can read a synopsis about these plans on your own so you can better guide and advise your patients and clients. So in terms of nutrition information, goodness, you can't avoid it in terms of all the claims, all those media stories, the social media that's out there that confuses us, and I know confuses the public. When you look at the mixed messages, when you look at even, where old messages are overturned and new philosophies are put out there. So we see that constantly. So where do you and your patients get nutrition information? In today's world, the majority of that information is found on the internet. People searching terms or running across it on social media, online websites. So that is where most people are acquiring their nutrition information, which of course can be questionable at best. With all kinds of motives of these websites, all kinds of, misinformation out there. Health professionals are valuable sources, of course, of nutrition information, particularly, nutrition professionals. When you look at the health professions as a group, it's hard, to be able to address sometimes the specific nutrition questions you might be receiving. And, people are getting information from something they hear from their friends or their family, coaches, trainers for some of the athletes, and of course, other media like the news, television, documentaries. Those are sometimes kind of scary that are out there that are nutrition related documentaries. So just as an example, intermittent fasting. I get lots of questions about intermittent fasting from students, from even friends, people that are, embracing intermittent fasting or asking questions about it. And certainly if you look at the press, we see mixed messages. This is a story that came out, I forget exactly, this was from April. Intermittent fasting isn't a magic diet trick after all. That was kind of a reversal on some of the positive press we were seeing about intermittent fasting, and we'll talk about this a little bit more. So this study, just like many studies that look at dietary approaches to weight loss, that there's no one best way, that there's no one approach that really is superior to any other approaches. And we'll look at some of those kind of things today. So in terms of, one thing to remember, that intermittent fasting is not the same as time-restricted eating. Intermittent fasting is more so like an alternate day fasting, 5-2, where people fast, quote, 2 days of the week, not necessarily consecutive, and quote, eat normally the other days. Time-restricted eating is when eating is constrained to a certain window. So they're really not one and the same. And so when you look at studies, when you look at research, you need to look at, what are they looking at? Are they looking at time-restricted eating? Are they looking at intermittent fasting? And this study just showed, this came out in April again, that was no more beneficial than just reducing overall calorie intake in this study, either in terms of weight or metabolically. And this is a slide that I love. I've used it for years. I use it with my students. I use it in other groups, just the weight of evidence, and to help not only fellow professionals understand, but to help our patients understand that in science, nutrition and other sciences, it truly is a weight of evidence that, what we're learning in nutrition is such a really young field in so many ways, that there may be studies that are showing one thing, but then there may be a study that shows something else, and then another one comes out and that rock goes on the other side, so that it is an evolving, changing science, and it's hard to do definitive answers. I joked with a cardiologist the other day that I said, I answer almost every nutrition question to start with, it depends. It depends. Because, you have to look at the rest of the diet. You have to look at other variables, that there are very few definitive answers in nutrition. So this is something too that you might find valuable. So a few years ago, after teaching undergraduate students and some getting really passionate about nutrition and wanting a way to keep up with nutrition research, I started an educational Facebook page called Jamie Pope Nutrition Prof. So about once a week, I post stories here on this Facebook page. I'm not selling anything. It just, I kind of look and watch what's coming out in nutrition and write on it. Today, for example, I did a post about a new study that came out that found that over almost 10,000 people were asked to evaluate whether their diet was excellent, very good, good, poor, I forget, there were 5 parameters. And 85% of the participants in this study overestimated the quality of their diet, that people thought they were eating a lot better than they were because they looked at, dietary questionnaires and recalls and were able to compare actual intake against their own personal assessment. And so, it was just interesting to me how many people, and I thought of this as a pediatrician with my 17-year-old, that the nurse just asked, so do you eat pretty good? Do you eat healthy? And she's like, yeah. I kind of beg to differ, but that was the screening question. And so not to, say anything critical, but, people tend to think they eat better or they claim they eat better. And, how do they assess what's quality when you ask them? So many interesting things here, but you might consider checking this out, because I do try to write in terms of evidence-based, usually a link to research articles and other things, just to kind of keep not only students, but my colleagues even up to date on some of the things that are coming out. So it might be an easy way to follow along. So evaluating health information, there's so many things out there. You have to look at who wrote it, what's the source, what's the date that it was done, has it been updated, and those kind of questions. Just to say a few things here, and this isn't carved in stone, but in general, you can lend more credibility to sites that end in, and you probably already know this, .gov, .edu, .org. Not always, but usually those, you tend to can feel a little better about. .com certainly is not across the board. There's some excellent .coms, but many may be selling a product or have different motives. So even the suffix on a website would be kind of a indication, and watching too, of course, and letting your patients know, is this based on research, randomized control trials, is it reviews, meta-analysis, or is it just anecdotes or an quote expert spouting information, so to speak. And, just looking at those. Now this I'm going to share, and I think it'll come up. Let me see if it'll open for me. I just want to show you one way that I kind of look at things. And I think I have to do a new share to get this to work. So this may not be the most incredibly professional way, but it's a way that if I get asked a question, where do you start? Do you go to PubMed and type it in, try to find and read through all the research? Sometimes that's overwhelming and you don't have time for that. And yet Google can sometimes give you misleading things. So oftentimes I will put in something like, I got a question yesterday on the FODMAP diet. And so I put in FODMAP, go to news, and then look at your news sources on these FODMAP stories, and scroll through, look for a credible news service. Oftentimes, here's one I'll just click on. Oftentimes, if you look at these news stories, they will give you kind of a synopsis of new research. And oftentimes, they will actually give you, come on and open, it's not opening. They will often give you a link actually to the research article that they're talking about. So it's a good place to start. It's a good place to find information fairly quickly. And it's not working, but that's okay. So let me go back here. And that's just something I do, is I go to Google, put in a term or a topic or a question, and then look at the news stories that have come out, some very recent, and then skim through that. It often gives a nice synopsis of research studies, and very often either gives the name of the researcher, which you can then use to plug into a search engine, say PubMed, or an actual link to the actual research study. So that's just a thought I had in terms of all this nutrition stuff coming out. So there's lots of sources for credible nutrition information. I'm, of course, not going to go through all of these, but of course, from the Academy of Nutrition and Dietetics, some of the government websites, the Harvard School of Public Health puts out lots of good stuff. Of course, PubMed is always a good source to look for some of the studies that are out there, and NIH, and then a variety of nutrition news sources. And I have some of these specific for the Academy in just a moment that I'll show you. And again, these are just some of those, which also include, you know, some of the health associations, American Heart, American Cancer Society. Of course, all of those are good, credible sources that both you and you can refer your patients to. In terms of the Academy of Nutrition and Dietetics, one thing I was sharing before we opened up today was I was delighted to see that associate membership in the Academy is available to advanced practice nurses, not registered nurses, but nurse practitioners for $70 a year. This gives you access to all the professional resources available in the eatrightpro.org, which is where you find the evidence analysis library, where you find access to the journal, all the position papers. And you could also put that on your CV or your resume that you're an associate member of the Academy of Nutrition and Dietetics. So I thought that was pretty exciting news. Of course, for your patients, eatright.org is a great resource for a variety of nutrition information, and Eat Pro is the one that is utilized for professionals, for registered dietitian and associate members. This is a wonderful resource, this Nutrition and Dietetics Smart Brief. You get it in your inbox Monday through Friday. It gives a very brief synopsis of new nutrition research coming out, even if you're just interested. And it's amazing how much it often correlates to what your questions might be, because it's the new stuff. It's things people are reading about. It's studies that have been picked up by the news outlets. So just to show you today's, let me share that. So this is the one today. This is the one I mentioned, the survey about 85% of Americans and diet quality. But it also has a variety of other information, you know, just some articles from dietitians, anti-inflammatory, salmon, taste-related genes, allergies, irritable bowel syndrome, and celiac, and then some other research articles that are reviewed from a variety of journals. So this is free, and it is called Nutrition and Dietetics Smart Brief. So that is a really great resource that you might consider. Also, there's the Academy Physician Practice and Consensus Papers. If you click on this link, it will have 147 position papers by topic. So many of the clinical related questions that we received, they're position papers or practice papers on many of these topics. Dietitians can't keep up with all of them either. So these are either sometimes consensus with other organizations, but kind of the position of the Academy. And then there is also an evidence analysis library that has systematic reviews and evidence-based information. And that is part of Eat Right Pro, but also an accessible and great nutrition resource. So kind of transitioning, I know we've got a lot to talk about today. We're going to talk some about obesity. So I was looking, the latest stats that came out are from still 2020. And at this point in time, when you look at obesity prevalence, it was almost 43% nationally. And when you looked at overweight and obesity combined, it was almost 74%. So very alarming. Of course, these are BMI based, BMI above 30 in adults. And you can also see some of the disparity across different groups down at the bottom of the slide in terms of prevalence rates. And that the highest prevalence rates are in adults age 40 to 59. And again, you can see that the Southern US kind of has the brunt of the obesity prevalence with the higher rates than some of the other parts of the country. Excuse me. We don't know yet. I've looked for this data, and there's some, of course, predictions, but in terms of actual estimates, we don't know the impact yet of COVID. We have seen some studies in children with increasing BMI and increasing pounds of weight gain during COVID. We do know that certainly obesity complicates the whole situation in terms of occurrence, in terms of complications, in terms of hospitalizations related to COVID. And so here's just a resource here with COVID and learning more about that now. But there is a lot of concern across all our health professions in terms of what are we seeing in terms of the impact of COVID? You know, have people started eating better? And, you know, or has weight gone up? Or are we seeing more comorbidities? You know, because of, you know, understandably, our focus has been on more the immunity and in terms of the alarming rates of COVID prevalence versus some of the other health issues that we experience. So in terms of dieting, fewer Americans, quote, dieted in 2020 than in order to lose weight than in the past, but it's still ranked number one. But 2020, this survey began to see some of the impacts of COVID, that people were beginning to think more about, they wanted to eat better to improve their long-term health, to boost their immunity, for other variables, for energy, you know, to reduce risk of certain health conditions or to treat those conditions. So we are seeing some changes in what is motivating people to change their eating or activity patterns. So I wanted to share a little bit from this. In 2013, the American College of Cardiology and the American Heart Association and other organizations as well updated the guidelines for management of overweight and obesity and put out a huge report. It was an update from 2000. So it took them almost 15 years to come out with the newest edition of the guidelines for management. And one thing that it looked at was the efficacy of diets of different forms and structures on weight loss and achieving weight loss and maintaining that weight loss, and what were some of the benefits and risks of those approaches. So this is basic weight control, is that you have to lose weight, you have to create an energy deficit in some way. And basically all diets, quote, that's their ultimate outcome, is they're in different ways, different approaches, creating an energy deficit so that body weight changes. Of course, there's many things that enter into that equation, but when this report came out, it said there's different techniques that can be used for reducing energy intake. You know, the old one was just assigning a specific calorie level, you know, 1,200 for women, 1,500 for men. I remember the day, I'm sure Hannah does too, where you just would do a basic, quote, calorie prescription, so to speak. And certainly those levels are low enough for most people to produce an energy deficit. The other one was to estimate individual energy needs, and then take off 500 or take off 1,000 calories, and that would be their calorie, quote, level. So that was another way. And then the third approach was not to give a formal energy deficit, but through different mechanisms, whether it be different food group manipulations or macronutrient manipulations, that you would ultimately achieve reduced energy intake. And the third one is kind of what most diet approaches are doing, is they're taking different ways to approach getting a deficit. And I remember I started working in 1980s in the Vanderbilt weight management program with a, quote, then diet doctor who came out with a variety of approaches, and we tested a variety of approaches, and he used to call them the SDTs, same damn thing, that every diet really was just another way to eat less, and some included moving more, but most were just getting you to ultimately eat less in some way. So this is what the ACC-AHA guideline looked at, a variety of different approaches with higher low carb, low fat, Mediterranean, just a host of different approaches. Some, of course, have come out even since this report in terms of popularity. One question to ask, and that's being asked more often, is should you even advise people to lose weight? Not only given the fact that it's very difficult to not only lose, but certainly sustain a weight loss. The percentage of people that are, quote, successful at weight loss and maintenance is relatively small. And so, when do you recommend? And when you look at the guidelines, it's usually if BMI is above 30, particularly with a comorbidity, and sometimes even a lower BMI than 30 if a comorbidity or more is present. So certainly some of these obesity-related conditions can warrant the recommendation to manage weight, but it has to be handled very delicately. And so these are just kind of guidelines, and certainly how we deal with individual patients and clients is very different. But of course, all of these increase risk, not only for chronic disease, but also, impacts on longevity. So this is again from the guidelines. There's more and more that we're learning about matching approaches with metabolic variables, and that some approaches may be more successful in terms of moderating risk and changing some of the metabolic, like lipid levels, blood pressure, some of those things, with a different type of approach. And we also know that the magnitude of weight loss and the maintenance of that weight loss also dramatically produces risk. You can see some very clinically significant changes with modest weight loss of even 3 to 5%. You see greater metabolic impacts with weight loss that's achieved that's above that level, but that's sustained. That's the biggest variable, is a short-term weight loss even worth it? Because it can mess with your mind. You may see some short-term improvements, but unless it can be sustained, and what it takes to eat and move at a lower body weight can be very difficult. So this is just kind of the wave of the future. We're very new in, say, nutrigenomics, but more and more people are looking at clinical measures in terms of, when a patient asks what type of approach, and I get really mixed feelings when I think about ever recommending a diet to people. And we'll talk about, some of the ways you might do that, but this is interesting information, and what type of approaches may produce some of those changes clinically. So one term that's coming out more is metabolically healthy obesity, MHO. That these are individuals that may have higher BMIs, but don't present with elevated lipids, don't present with insulin resistance, don't present with elevated blood pressure. And, how do you deal with those? And this is an interesting article that looked at that and, definitely affirmed the large variation in individuals, that you can't just look at BMI, and hopefully we're getting away from just using BMI. But this is interesting. But this article ultimately did conclude that metabolically healthy obesity should not be considered a safe condition, which does not require treatment, but can guide decision-making. So it's monitoring people, it's watching things. Sometimes I think a strategy of weight maintenance is very powerful, helping people just sustain a weight rather than, many people creep up over the years. So just helping people sustain their current weight over time can sometimes be approached too. So I have given you a couple of references here if you're interested in reading more about the concept of metabolic health. And there are basically 3 approaches to achieving this energy deficit. And the first one, of course, is diet, movement, physical activity, behavior modification, intervention programs, lifestyle intervention, and that is across the board. And then there's the second tier would be some of the anti-obesity medications that are out there. And one was approved fairly recently. And those are to be used in combination with the first one, not on their own, that they are just kind of a dual or an adjunct therapy. And then I gave you the link to some of the current medications that are currently approved. The conferences that I've gone to on obesity, there's a lot of feeling that these medications are actually underprescribed, that many practitioners are not comfortable with prescribing them. They don't always know their mechanism of action, and that they really may have more benefit and therapeutic impact than are currently used. I'm not advocating for these drugs, but sometimes they help with compliance. Sometimes as an adjunct, but they do have to be looked at as long-term. They aren't necessarily, going on for 3 months and lose 20 pounds, then go off. That more than likely the weight will resume. And so they have to be looked at as this is a long-term intervention. And of course, the third one is more dramatic intervention with surgery, with bariatric type surgeries. So this is, again, treatment and primary care of obesity. And just some of the takeaways from this are that to be open to the idea of using medications, treating obesity as we treat other chronic illnesses, and show respect and empathy. We'll talk a little bit about how to talk to patients about obesity, because it is a very difficult conversation sometimes to have with people. Redefining what success is with more modest weight losses that could potentially be easier to sustain. And moving on. So this is old, but it's still used by insurance companies. It's still used by many practitioners in terms of how you approach treatment modalities based on body mass index. And you can see the diet, exercise, behavior therapy is across the board. And then pharmacotherapy is only with overweight ranges that are also presenting with comorbidities, and then above a BMI of 30. And then, of course, surgery, again, the higher BMIs until it would be ever recommended or approved for reimbursement. So this chart, it has as many issues as BMI may have. This is still one that you're going to see utilized, certainly by when you're looking for any coverage or reimbursement. And so another takeaway is that, like we've already said, most diets result in reduced calorie intake. And when you look at the studies, there's really not much variation over time. There may be, for some approaches, greater initial weight loss, but when you take it out 1 year, 2 years, you see very little difference between the variety of approaches. And, some are certainly healthier approaches in terms of food and nutrition. And again, redefining what success might be. But when you look at all the studies on low fat, low carb, all that, there's really no conclusive evidence. Of course, you're going to see that difference between some studies, that the degree of weight loss or the duration of that weight loss are significantly affected by how you manipulate the dietary macronutrients. It kind of comes down to what can people do, what's sustainable, what's their metabolic profile, and what kind of, willingness they have to even embark on some of these. Is it something they could sustain in their life? That's a huge one. So again, all diets work when adhered to, which is very true. And weight loss is highly variable between the different approaches. And I mentioned earlier that some of the metabolic profiles, so that, folks that have, elevated LDL sometimes do better with a lower fat approach, and, the triglycerides, a lower carb approach, and, with the HDL. So you see different things that we're learning about some of these. And we know that potentially increasing protein for its satiety value and for a variety of other things, along with keeping fat moderate, since fat is the densest source of calories, may be a longer term approach. And this is another excellent article. What do we know about energy balance and weight maintenance? But I want to jump on to some other things. These are just some studies that I've included that you can, again, go back if you're interested and read some of these. And again, a lot of them come back to adherence and sustainability is what should be considered, not necessarily the magic, so to speak, of any different manipulations. So what we do know is that what appears to be, most effective is, changing that energy balance equation with more physical activity, reduction in overall calorie intake by just making some tweaks sometimes, or helping people, reduce sugar intake, emphasize some of your less energy dense foods in their diet, moderate fat, since fat is the densest source, but emphasize healthy fats and moderately high protein. The average intake of protein in the US is around 13 to 15% of calories. So some of these are looking at 25 to 30% of calories from protein in terms of both that. And the value of this energy density. When we look at some of the popular weight loss diets in a moment, I'm looking at the time, Noom, volumetrics, I'm trying to think of the others. Many of the plant-based diets really have more of a, one way that they quote work is that you lower the energy density of your foods by choosing more plant-based foods that are higher in fluid content. Just a lot of the different variables. When you look at what changes energy density, fat, sugar, and alcohol increase energy density of foods. Whereas fiber and fluid or water decrease energy density of foods. And so you can eat more if you're eating, and you can see here the difference in these two meals in terms of volume with the same number of calories. And it has to do with the foods that are chosen and their energy density. So as for me personally, the more bites I can eat, the more I can, the better it is. And it feels less restrictive. So guiding people towards a less energy dense diet. And this is, again, clinical trials show that reducing energy density is effective for weight loss. And there's a lot of different approaches that can help facilitate that. This is a wonderful chart. If you go back and look at anything, this is just a summary chart looking at the macronutrients, looking at fiber, looking at beverages, added sugars, and some of the recommendations there. This is a summary of nutritional goals, and it just has some great tips in terms of just general guidelines to help people not only, eat healthier, but eat potentially a calorie level that is more conducive to a healthier weight for them. And just, in general, a good foundation. So you've got to consider a lot when you look at, dietary approaches. And I want to get on to the diets because I think that's going to be more interesting for us. But so we're going to look at a few ways to look at these diets. Because if you go in, like I went into PubMed today to see if there was anything on Noom, nothing, no results on Noom. So how do you evaluate Noom? How do you figure out, is Noom something that I should be advocating for my patients? Is Noom something that, what can I tell my patients about it? So every year, every January, US News and World Reports comes out with a report called Best Diets, and it looks at, quote, diets in a variety of different ways. These are the best diets overall, not necessarily weight loss diets, with Mediterranean and the DASH diet tying for number one, flexitarian up there. If you look through these, most of these are more plant-based diets. And like keto's ranked down towards 40 in terms of this ranking. when you look at a diet like that. But I wanted to show you, these are the weight loss ones. So they ranked, and what they do is they have a panel of health professionals, a variety of different disciplines that review these diets, look at a variety of factors. And on the last slide, it said what they looked at. I didn't include it on this one. They look at, nutritional values. They look at, sustainability, weight management over time. They look at, a variety of factors that help them determine the parameters to select, quote, best diets. So when they looked at weight loss diets, flexitarian, volumetrics, and Weight Watchers all tied for number one. And all of these endorse and recommend a wide variety of foods. They don't restrict any food group per se. They're mainly plant-based, emphasizing more plant-based foods, vegetables, fruits, beans, legumes, don't necessarily eliminate meat, even flexitarian. And, you kind of look down at the others. And so if you go and look at some of these, and let's take a look at Noom, because we had a couple questions on Noom. So if you go to Noom on this website, let's see where it is. Here we go. So this is Noom here in this one. And it kind of gives you what is Noom. So you can look at all the different, factors, the pros and cons. Says you're glued to your phone. It also costs money for a Noom, so it can have an expense to it. It's truly an energy density based diet in that it's most of the recommendations are helping people choose less energy dense options overall. So, and you go down and how does it work? What are the things, these green foods? Yeah, so it gives you some of the information, what you can eat. It even tells you some of the research that might have been done. And like I mentioned, I had a hard time finding any, and I don't really see any here. But, I've personally had a couple of friends that have had a lot of success with Noom. I don't think it's a bad diet. It does kind of, the fundamentals are pretty good, but it'd be interesting to maybe read a little bit more about it if you have a lot of people asking about that. And then, here's another review on keto and intermittent fasting. And you can see the rankings. If you look on the left side of the screen, most of these, quote, diets are more plant-based. Most of them are recommending foods that have lower energy density over the ones that have higher energy density. Some are going to, quote, be a little stricter than others. So part of it is, I've worked in the area of weight management for decades, and I'm a big believer in nudging and tweaking, but, helping people identify some reasonable interventions that oftentimes they can identify. You don't even have to identify them. Like, what 2 changes do you feel might make the most difference for you? And sometimes it's, drinking, sugar-based beverages or portion sizes. So, helping people just kind of tweak instead of go on a diet that's oftentimes short-lived and restrictive and often doesn't work within the constraints of their lives. So, but it's not an easy thing. And sometimes the structure of some of these plans, and several of them support systems like Weight Watchers. Noom even has a community that sometimes that can be very valuable to people. Is just to have, kind of cheerleaders along the way, and not trying to go for big losses, but to just kind of find a balance in their lives in terms of activity and in terms of, what they can do in a reasonable way with their eating and exercise and food choice. And environmental control is so powerful. And by that, I mean what we surround ourselves with, where we go, how we do things, where we're not fighting our environment all the time, I think can be very powerful too. Another place to look for diet reviews is Harvard School of Public Health, the nutrition source there. And here's a link to that. Here's some reviews that they have, which I have read many of these and looked at them and feel like they do an excellent job of looking at the different factors with pros and cons and considerations for health professionals in recommending these, but also for individuals. So, here's one for intermittent fasting, the DASH diet, quote, clean eating, which really is pretty meaningless. And it's not anti-inflammatory is another topic we hear a lot about too. And Forbes actually has some good resources. I have turned to Forbes when I've gotten a question on something that I haven't heard of before, to look there, between Harvard, between Forbes, between US News and World Reports. Sometimes some of these newer plans are not even among their rankings. So this is another really good source. And this gives a nice review, again, of Noom, of some of the things to consider with those kind of approaches. Then just a few things on just weight, obesity, and working with clients and patients. The American medical colleges are working on a new plan to kind of make physicians in particular more sensitive to their overweight and obese patients, that most of the research has shown less respect for these patients and oftentimes misdiagnoses because of just certain preconceptions. So I thought this was interesting, and this is pretty new coming out from that. And talking to patients about weight, when you look at some of the studies and some of the things out there, that patients prefer the terms weight and even BMI over using terms like fatness, excess weight, excess fat, or obesity, that those terms are, turnoffs to people and can feel offensive to them. So how you talk about it is important. And again, motivational interviewing, which we all hear about, and thinking about, again, about cultural relevance, and talking about eating patterns too in a non-judgmental way. I've cringed at sometimes the ways I even hear my colleagues approach individuals about eating patterns in a way that makes these judgments about people. And that is certainly inappropriate. Just trying to learn more about them, exploring things and helping guide them rather than tell them what to do. So these are potentially some good examples. If this is an area that you'd like to know more about, here's some resources as well, some references from a variety of sources about ways to talk to individuals about body weight in a way that engages them in the conversation, not alienates them. And this is, again, in dietetics, the phrase person first language here again, and what people responded to best, and not using the words like obese and fat and those kind of negative terms, which even saying them right now feels offensive to me. So that. And you probably all heard about health at every size. And again, this is another area of controversy that, some health professionals and nutrition experts and people that work in a variety of areas feel like we're taking this a little too far. But this is a very viable organization that's looking at health on a continuum. And again, trying to take some of the judgment out of counseling on body weight, and promoting more health equity. So this is more of a reference there. Hannah, how are we doing?
We're right at the 10-minute mark remaining, but this is awesome. These references are so great, Jamie. Thank you again.
Well, I'm going to share my slides, so you don't have to be taking notes. I'm going to, I know they're recording this session, but I'm also going to share with Betsy a copy of my slides so that you have access to these references. Because, I know it's a daily thing for me just to even begin to keep up and to address the kind of questions that come up from students, colleagues, and other ways with so much coming out. Intuitive eating is another one of those areas that is being embraced more and more, certainly within the nutrition community. It's another one too that's tough to know how to deal with. And, what does it mean? And how do you recommend it? And how do you counsel patients on what that is? So this just gives you a little information on that, rejecting the diet mentality, certainly getting away from labeling foods good or bad. There's no bad food, it's all relative. And good foods, good, bad. I see those terms still used sometimes, or the 10 foods cardiologists tell you never to eat, and, those kind of things in social media. So, this is kind of getting away from those black and white approach. The research is mixed on intuitive eating in terms of its viability in producing weight loss or long-term weight loss. That it depends on how it's approached and how it's utilized and how people are educated. It's not a free-for-all. It is not that at all. It's just really learning to listen to your body. It's learning to make choices under a different kind of paradigm than the diet mentality, but still taking responsibility for our health and for our food choices, and but not beating ourselves up, which never works out well. And so again, here's some reviews that look at some of the things in terms of mindfulness, in terms of intuitive eating. Now, this is a lot of information. So a couple things, we got a question about prevention of diabetes with diet. And of course, diabetes is as prevalent as when you look at some of the maps in terms of the obesity prevalence. Diabetes would look very similar in terms of type 2. Pre-diabetes, they're saying that potentially 2 out of 3 American adults have insulin resistance and pre-diabetes. And this is a brand new thing that just came out in May, dietary interventions to treat type 2 with the goal of remission. And this is an expert's consistent statement from the American College of Lifestyle Medicine, but it was also put together with a variety of health organizations, including the Academy of Nutrition and Dietetics, and focused on the importance of a plant-based diet in terms of type 2 treatment and obesity. And sometimes you think about, plant-based as being high carb, but this is endorsing more quality carbs that are going to have more fiber, more fluids, so lower energy dense carbs, reduction in intake of some of your refined flours and some of your sugars, and in favor of some other plant foods that are going to have more nutrient density and lower energy density. So this is another one. Diet as a primary intervention is most effective when emphasizing whole plant-based foods with minimal consumption of meat and other animal products. So one thing to remember too here is that plant-based doesn't mean vegan. Plant-based means emphasis on plant-based foods and using animal foods more as a condiment or on lower levels. But a vegan approach is not only hard to sustain for the vast majority of people, where you eliminate or severely restrict animal foods. So it's not necessarily something that people can live with for a long term. Also, you set yourself up for some potential nutritional shortfalls. So, if people go too strict, you have to find out, are they getting enough B12, D, B6, several of the minerals that are more concentrated in animal-based foods. So you really have to step back, the stricter the plant-based approach, and look at diet quality. Flexitarian, plant-based tend to not have those kind of risks in terms of deficiencies. If people are eating enough food, that's one of the big things too, is not overly restricting. But I think that's about all. This is another one on diet and drugs and using some of the anti-obesity drugs as an adjunct, which they have a variety of different mechanisms in terms of whether they, reduce absorption of fat, whether they increase satiety, both within and between meals. So, there's a lot of different mechanisms and a lot of different ways to use these along with a sensible approach. If obesity is such that this would be even warranted, or the comorbidities are such that this would be something. So I think that's all, Hannah. Whew. No, last time I didn't even get through everything.
Well, we've gotten a chat about resources for patients with celiac, Jamie, and I was actually going to put a couple of suggestions back in the chat around the NIH.
Thank you, Hannah.
But wanted to see, I think otherwise this is fantastic. And all the resources are just ever so helpful, because I know what it's like to sit in the exam room wearing both hats, dietitian and nurse practitioner, and needing these resources at your fingertips. So I know we're going to share the slides, and I think we'll continue to have conversations and look forward to future events. Any closing thoughts, Jamie?
Not that I can think of. We, as Hannah mentioned early on, we so appreciated the questions that came in. And I even talked to Chris Wilson in VUSN, in Medical Center. And just, her perspective was that, nurses not only need this type of information for, patient education and care, but also for themselves. That it's so hard in our respective disciplines to just really stay on top of things. And nutrition is like a moving target, with so much coming out and, so much misconception. Before we started today, I was cringing at a new store that opened that, had a big nutrition promo thing. And it's like, who owns this store and who's promoting this and what people are going to get taken in by it? And, there is just such an area of, we get inundated with so much information that it confuses us as professionals, much less the public, in terms of what's true, what's not, what do you turn to? And so hopefully some of these resources will give you some things. And I know we weren't able to get as clinically focused as some of your questions, but there are dietitians that you work with likely that would probably be very happy to talk with you in their respective areas, because we're as specialized now as most of you are.
Yes, and I would also put another ad, Jamie, that I'm seeing increasing amounts of insurance coverage for dietetics referrals. So that's something, especially in some of the private commercial insurers, as always another option around, especially some of the unique diets we're seeing now. So, well, this was awesome. Thank you so much. And we will work on distributing the slides going further. And with that, I hope everyone has a lovely evening. Thanks so much.
Thank you, everybody. Thanks, Hannah. Thanks,
Bye-bye.
Betsy.